break, everybody, and we've had a fantastic set of talks already, and now we're going on to Ilya Shpitser, and it's a pleasure to introduce him to you. He's the John C. Malone Assistant Professor of Computer Science. He's an expert in machine learning, AI, data science, and particularly in causal inference. At Hopkins, he's one of the really pedigree causal inference experts, having trained with Judea Pearl and Tyler Vanderweel, and one of the really important contributors to the field these days. He did his bachelor's degree at Berkeley in computer science and math, and his PhD also at Berkeley. And he's going to be talking to us about ideas from causal inference as they relate to disparities. So thanks very much to Ilya, and also thank you to him for his leadership role in putting this symposium together.
Thank you, Scott, for a very nice introduction. Can you hear me and can you see my slides? I'm hoping yes.
Yes.
Okay, great. Thanks again. I guess I can't really thank myself for speaking at this event, since I'm an organizing committee. This talk is a little bit unusual. We were really supposed to be one of the data science teams that will be speaking later, and I will actually do a second part of this talk later. But I thought I needed to give myself a little bit more time to explain what it is that we're doing, because there is sort of a methodological component to it. And what our team is interested in, so you can think of this as a longer extended lightning talk, if you like. What our team is interested in is understanding mechanisms behind COVID-19 disparities. And so this is joint work with Numair Sani, who is my student, my wonderful student, Nargis Amidi, who used to be Greg Hager's student and who is now faculty in Germany, Scott Levin and Jeremiah Hinson, who are faculty in emergency medicine, and my colleague Eric Chetkin, who is a statistician at the University of Pennsylvania. Well, COVID needs no introductions. We all know this. There are 90 million cases worldwide as of yesterday when I looked this up, 22 and a bit in the US. I actually think this is a severe underestimate, because I think we never really got on top of testing, either in the US or in the world at large, especially in the third world. There have been close to 2 million deaths worldwide, of which 373,000 were in the US. Again, this is already probably out of date. And again, I think this is likely a severe underestimate, because there is indirect evidence from all the excess deaths that it's probably a lot higher than that. Nevertheless, despite the horrible nature of the situation we find ourselves in, I think it is true that we were a bit lucky with the nature of this virus. It has a repair mechanism. It's a relatively slowly mutating virus, unlike the flu viruses, for example. The mRNA vaccine was amazingly effective, it seems, and we were lucky that this technology was developed in advance of this pandemic. Nevertheless, there are many challenges, of course, that remain before we can come to grips with our healthcare emergency here. This event is about the disparities in COVID-19, and this has been very well documented, and much ink has been spilled on this issue. COVID-19 was originally thought to be a respiratory disease, but of course we now understand that it is a complicated, possibly multi-system disease, and it attacks many organs in the human body. It potentially has longer-term after effects called sometimes long COVID, and it has heterogeneous effects in different groups, in particular ethnic groups or men and women. So this is a very simple example that I've just taken. This is just a screenshot of the CDC website, and you can see in this plot that if we adjust for certain obvious factors, there are many more deaths among Hispanics and non-Hispanic Black ethnic groups compared to, for example, non-Hispanic white groups. Death is not the only outcome for COVID that has a significant disparity. Minorities are known to get COVID at higher rates. Minorities are known to get severe COVID at higher rates. and so on. I mean, I think as far as I'm aware, most significant health outcomes have some sort of disparity of this sort. A lot of ink has been spilled on this, but the extent to, explaining why this is, I think is, it still remains an open challenge. Multiple mechanisms responsible for these observed disparities have been proposed. Dr. Cooper spent quite a bit of her talk discussing social determinants of health, of which there are many, and they could lead to various important comorbidities. So it's known that things like hypertension, diabetes, and possibly asthma are important comorbidities, and those can be affected by various determinants. Of course, there's structural racism, which we know is a significant problem in healthcare delivery. It is also possible, it cannot be ruled out, that there are certain relevant biological differences that are responsible by some of the outcomes that we're seeing, outcome differences. For example, there is some thought that vitamin D is protective, and different ethnic groups have different degrees of vitamin D deficiency. And of course, again, Dr. Cooper alluded to this. It's possible and indeed likely that multiple mechanisms are operating simultaneously to bring about the disparities that we're seeing. And so the aim of our project is to use modern data science methods to shed light on this, or try to. In particular, using modern causal inference methods, semi-parametric statistics, and machine learning. So in this talk, I will outline the methodological part, the methodological background that we will need to discuss the actual data part, and I will discuss the data part in my lightning talk later today. So association versus causation. So most scientific inquiry data analysis have one of two goals: association or prediction, so determining predictors or variables associated with the outcome of interest. So for example, at Hopkins, a lot of people work on adverse event prediction. And indeed, in COVID, a lot of the effort has been spent on developing models that can forecast severe COVID in patients in advance, which is a very important problem. The second type of inquiry you could do, or data analysis, is causal, which is understanding factors that cause or have an effect on the outcome of interest. And causal analyses are very important. Right now, we ran these, phase 3 vaccine trials, which were really aimed to establish the causal efficacy of various kinds of vaccine on COVID, like whether they have a protective effect or not. And so both kinds of data analyses are important. And of course, we know, and it's the oldest saying in statistics, that association is not causation. And spurious correlations, of course, are very common in practice. And so with that in mind, when can we claim an association is causation? And this is really what the field of causal inference is about, is disentangling these things. And so to give you a flavor of why this is important, so here is a famous example due to my advisor, Yehuda Pearl. It's a made-up example, but it's here to illustrate a point. So we recorded recovery rates of 700 patients who were given access to some drug. A total of 350 patients chose to take the drug, and 350 patients did not. And here are the results in the study in this nice table, stratified by gender. So we'll assume there are only men and women biologically here. And here is the table. So you could check that all the fractions add up. And so the question given this table is, was the drug helpful? And what's slightly weird about this table is you can see that without stratifying by gender, more people in a no drug arm recovered than those who were in the drug arm. However, if you stratify by gender, both men recovered more frequently and women recovered more frequently than men, which is somewhat paradoxical. So in statistics, this is called the Simpsons paradox. And the fact is, we're faced with questions like this very often. And so this can occur in real data. And causal inference can help you make sense of seemingly paradoxical nature here. And so without getting into too much detail here, the key here is to notice that stratifying by gender is, gender is a very basic fact about you. It's a pre-treatment factor. And saying that it's a pre-treatment factor, meaning the treatment doesn't cause it, is side information. It's causal information that isn't present in this table. And so in this case, you would want to stratify by gender when making these kinds of treatment decisions. However, if I were to relabel this table with the side effect of the drug rather than the gender, then the side effect will be causally consequent of the treatment, and then the decision would potentially be different. Okay, so in classical causal inference, we think about treatment effects, and a basic ontological unit in causal inference is what's called the potential outcome random variable, which is the response Y of some person I if they were given, possibly contrary to fact, some treatment A. So this morning I had coffee. and I don't have a headache, and I would be interested in knowing whether I would have had a headache if I did not, contrary to fact, have coffee this morning. And so so this sort of corresponds, these kinds of variables can be used to set up this kind of hypothetical randomized control trial. And we know that randomized control trials are a gold standard for establishing causality. And the only difference, of course, is that we don't necessarily are able to run such a trial, and we just want to use observed data to see if we could predict what would have happened if we did. And so typically you use these potential outcomes to build certain causal parameters. So here, the causal parameter is called the average causal effect, and it represents the outcome comparison in two arms of this hypothetical trial, where you gave some people coffee and you didn't give other people coffee, and that was randomized, and you're interested in whether on average one arm gets the headaches more often than the other, something like that. And of course, we assume here that if I drink coffee, it doesn't affect someone else's headache, which is called the no interference assumption. And the problem, of course, with making these kinds of inferences from observed data is for every person, they either have coffee or not. So you never observe both of those situations at once. So it's a kind of missing data problem, as they say in statistics. And second problem is correlation is not causation. So in observed data, whether people drink coffee or not is not randomly assigned, but it's based on their habits. And maybe people who are more likely to drink coffee are also less likely to get migraines, who knows? So there could be some spurious associations between these variables that make it difficult to assess what the causal relationship actually is. And so the way causal inference works is you try to formulate a question of interest as a hypothetical experiment we might want to do. For example, in this drug example, is the drug helpful? Compare outcome for person I if we gave the drug versus not. And then we'll define relevant variables. So in that Simpsons paradox example, the relevant variables are, biological sex or gender, I guess is imprecise, the drug and the outcome. We can define a causal model, which kind of says which variables influence each other. And this could be obtained from experts, background knowledge, or learned from data. And details, by later, I mean later in this talk. For now, we can say that gender causes the drug, gender and drug both cause the outcome. And then we could formalize, given the model and what we're interested in, we could formalize it as some sort of parameter in the causal model, which is average versus gender-specific causal effect. And because we're interested in contrafactual parameters, we don't necessarily get data on them. So that means we need to link the parameters we're interested in with the data that we have, which is called the identification problem in statistics. And in our case, the effect is identified. And once we have an identified parameter, then it just becomes an estimation problem. And then we could pick an estimator using statistical or machine learning models, fit this estimator using data, quantify its uncertainty, report confidence intervals or credible intervals if you're a Bayesian, and assess assumptions, which is sensitivity analysis. So classical assumptions, which I'm not going to get into too much detail because I don't have that much time, is what's called the no interference assumption and the consistency assumption. No interference just means that if I drink coffee, it only affects me and nobody else's headache, roughly. No interference actually doesn't work in infectious disease like COVID because people can infect each other. And so if somebody is vaccinated, for example, as a treatment, that could protect their roommate, for example, even though the roommate was not vaccinated. That's the basis of herd immunity, the fact that interference fails, or lack of interference assumption fails. The consistency assumption just says that roughly that every variable is determined by a stable causal mechanism that doesn't care whether treatments were set contrafactually or set naturally. And then we make some assumptions on the relationship between outcomes and treatments. And the goal is to express some sort of contrafactual representing a causal parameter of interest as a function of the observed data. Okay, and so a simple model is what's called a conditionally ignorable or backdoor model. So here we have, let's say we have a drug, we have some outcome such as death, and C is a health status or gender or something. And we assume that conditional on the baseline factors such as health status or gender, the treatment is independent of the outcome, potential outcome. And under this assumption, we can actually express the average causal effect as a particular functional of the observed data, which is this middle line here, which is a kind of an averaged out regression comparison. And there are various kinds of estimators that people came up with, such as the plug-in estimators, inverse weighted estimators, and so on. So, but we're interested in using causal inference to assess mechanisms of disparities. And so what we really want to do is you want to think about race. And of course, race is very complicated. Anybody who studied race, is really a high dimensional object, like a vector of various things, including social determinants, family considerations, the way you're perceived, maybe certain relevant biological things as well, and how race, that giant vector, affects outcomes via various pathways mediated by various variables. And so this is studied by something called mediation analysis. So here's a simple version of mediation analysis problem. You have a set of baseline factors, some sort of complicated treatment like race, a mediator and an outcome. And this treatment has a mediator-specific component, AM, and an outcome-specific component, YM. And so this is, sometimes people draw causal models as graphs. So here is a graph. Here, variables are vertices, and blue arrows represent roughly direct causation, or something like that. So here's the model, and the indirect effect we formalize as a hypothetical randomized study where we fix the component of the treatment, such as race, that has to do with, or of some other treatment that has to do with the outcome directly to some fixed value, and we try to change or manipulate the component of the treatment that has to do with the mediator. So for example, we may be interested in what component of smoking is responsible for lung cancer. And we could imagine that smoking, which is a complicated treatment, has two components, whether you have smoke inhalation and whether you get nicotine. So YA here would be something like whether you get nicotine ingestion or not, and AM is whether you have smoke inhalation or not. And so we could imagine fixing nicotine ingestion to a particular level and then varying whether you inhale smoke or not. And so this corresponds to a lung cancer rate. You compare it to smokers and to people who are nicotine patch. In other words, people who maintain constant their nicotine consumption, but who change whether they get smoke inhalation or not. And so this tries to get at the mechanisms of smoking that are responsible for lung cancer, which we actually think is smoke inhalation rather than nicotine consumption. So that's the way mediation analysis works. And of course, this is a counterfactual parameter because in the data, we either people smoke or they don't smoke. And of course, whether they smoke or not depends on baseline factors C, and it's not randomized at all. And so there are certain standard assumptions that I'm not going to get into too much detail that can be read out from the graph. And under these assumptions, this contrast where we manipulate just one component of the treatment ends up being this functional of the data that I show in the middle, which is a slightly weird kind of adjusted regression comparison. And so this converts the problem about contrafactual contrast, where we manipulate certain components of the treatment into just a functional estimation problem in statistics. And so if we have a well-specified parametric likelihood, we can estimate this by maximum likelihood plug-in estimation, just fit models for all the objects here and just evaluate them there. And this is not really realistic in high-dimensional applications because we cannot really get parametric likelihoods. So instead, we can leverage same parametric theory in machine learning. So, so what we can do is we can develop what are called regular asymptotically linear estimators. And for a particular parameter psi, these estimators have the following form. So we end up summing over every row of the data, and at every row of the data, we evaluate a particular function of all the observed variables called u of z. This function is called the influence function for the parameter, and there is a little bit left over, this little O of 1 term that goes to 0. Here our psi will be the mediation formula on the previous page, that middle thing. And our prior work, this is with Eric Chetkin, my colleague, we derived the efficient influence function, so the one that uses the data most efficiently for that target, which is given by this formula here. And to estimate psi, we just solve the estimating equation with this object by just taking the expectation with respect to the observed data, setting it to 0. And the nice thing about these kinds of estimators is they're as efficient as could be, while also allowing flexible machine learning methods to be used with all the nuisance models that appear here, for example, the outcome regression and the density of the mediator here. Okay, so what are we really using all of this theory for? We're interested in quantifying mechanisms of COVID-19 disparities. So we're going to use this methodology of causal inference and identification theory that allows us to express, we're going to think about disparities as some sort of hypothetical trial. If we think about race with many, many components, components that lead to structural racism, components that have relevant biological factors, components that lead to pre-existing comorbidities. We're going to try to set up a hypothetical trial where we manipulate only one of those components and think about the outcomes. And in that way, we'll try to quantify how much of the observed disparity having to do with the outcome is attributable to manipulating that one component. And then we'll try to use identification theory, semi-parametric functional estimation theory, and machine learning to try to use observed data obtained from electronic health records to try to get at this question. And so in the shorter talk later today, in one of the lightning talks, I'll tell you a little bit more about the data we plan to use, but it's data available at Hopkins and some data from Germany. Okay, so here are some bibliography and mediation analysis that I was involved in. This is mostly on the methodology end. This is the grants that I wanted to gratefully acknowledge that were used in developing a lot of this work. And that's all I had. Thank you very much.
Thank you, Ilya. Thank you. Do we have a time for a question or two? If you would like to ask a question, just open your.
Yeah, just speak up.
Can you hear me?
We have plenty of time.
Okay, great. So why don't just unmute yourself and ask.
Hi, Ilya. This is hey, nice talk. This is Phil Fan. So just a quick question. So, you know, in the model that you described, the mediators, I mean, at least the way you've laid it out, assume to be independent, right? But
oh, they're not.
They're
not assumed to be independent. So mediators could be associated with each other. I think in the simple example that I described, we just had one mediator, so the question was moot. But in reality, like in the real data application, there will be many mediators. There's going to be a mediator for important comorbidities like diabetes, and there will be a mediator for economic precarity, and there will be maybe biologic ones as well. And they're all potentially correlated, and that's fine, as long as we know what their relationship is.
Yeah, so actually my question is that knowing that these mediators are correlated, and they might be correlated in many different ways, right? One way, two way, three ways. I think, you know, your idea of the machine learning model makes sense, but in that case, how do you, so will it be like unsupervised? I mean, how would you apply machine learning to data under some theoretical construct when you have these very complicated interactions that are occurring? And then after that, how do you actually tease it out? So assuming that if you have a theory with a lot of very different interactions is one thing, but if you don't know what those interactions are, then of course you use an unsupervised method, but then you still end up with trying to understand what exactly is the mechanism. If the idea is to derive a mechanism, how do you actually do that when you don't have a theoretical formulation for these interactions, or if they get too complicated?
So thank you. That's a great question. It's a complicated question. So I'm going to try to go step by step. So causal inference is a multi-step process. So the first thing we did is we tried to define what it means for there to be a mechanism of disparity in terms of a hypothetical randomized trial. In other words, we're thinking that race is this complicated vector. We're going to think about various components of race that are associated with certain downstream mediators, for example, comorbidities, or for example, biological factors, or for example, structural racism. And we're imagining that there is a hypothetical study where we're wiggling one of these components that affects only diabetes, for example, and not anything else. So imagine we could run a hypothetical study like that. So if we did, and we wiggled that particular component and we saw a difference in the outcome, that would explain some of the disparity, the fact that the difference is changing if we wiggle only that component. Okay, but we can't actually run the study. So what we need to do is we need to use observed data to predict what would have happened if we did the study. So then this is where all this causal modeling stuff that I kind of skipped through goes through. So it makes certain assumptions relating the contrafactual variables we need to represent this hypothetical study and the data we actually have. So here they are listed on this slide. And so under those assumptions, you can show logically, which again, I skipped for time, that the outcome comparison in that hypothetical study is equal to this function of the data, this last formula here, okay? And so this is a function that we can estimate. So one way we could estimate it is we can just look at it and see, oh, look, there is an outcome regression here, and there is a density of the mediator given the A and the C in here. So we could use machine learning to fit those things somehow. So that's a supervised problem because fitting regressions is supervised because we have outcome labels. And then averaging, taking that integral, which again, we can do, we can empirically take it. So we use machine learning as a subroutine, supervised methods in machine learning. But it's a subroutine to try to estimate a parameter which is counterfactual. Because the parameter is counterfactual, the problem of estimating that parameter is not really supervised. It's kind of half supervised because we only see it in half of the people. Half of the people, could drink coffee, half of the people didn't. Or for people who did drink coffee, we don't know what happens if they didn't, and vice versa. So in causal inference, you don't have the labels for everybody. You only have the labels half the time. So the subroutine that's used to solve causal inference is a supervised problem. The overall problem isn't, which is why we have to be very careful and multi-step about it, and which is why once we do the analysis, we have to actually do a sensitivity analysis to assess whether the assumptions that we made were reasonable or not. We can't just do what we do in machine learning and just like do held out data.
Right.
Okay. So I don't know if that helps.
Yeah,
because
yeah.
you asked a complicated
Very cool. Thank you. Yeah. Very cool. Thanks.
Yep.
Other questions?
Hi, Ilya. Sorry. Hi, Ilya. This is
Hi.
Jim. Great talk. I was thinking about the method you were showing and how you would consider multiple variables for relative contribution.
So that's your question. How would I do that with more than one mediator?
Yes, particularly
Okay.
since when you generally think about health disparities, there are multiple, like a long list of variables relating to like a person's demographics as well as their socioeconomic variables. So when you think of that type of construct, I think it kind of follows to the question you were just asked. Would you think of a supervised method, or would you think of a some form of factor analysis?
If you're okay, so I'm going to do causal inference. So causal inference is not supervised, so that's not going to work. Factor analysis is also not a causal method, despite what some people will tell you. So I'm not using that either. So if you're specifically asking me about how I would use multiple mediators, well, really what happens then is you have to think about the entire model and the fact that you have race, which is something complicated. And race affects the outcome by multiple causal pathways that go through multiple mediators. And we have to decide which pathways we want to talk about. And usually in mediation, we think about what are called direct effects and indirect effects mediated by a single variable, a single mediator. But in general, you have what are called path-specific effects, which are effects associated with particular causal pathways. And I mean, there is a way to do that. There is a way to say there is some sort of disparity, and I could decompose this disparity into a set of numbers, a sum of numbers that represent the way in which a variable affects the outcome through some pathway, and then just sum over all the pathways together. So that's like a path-specific effect decomposition. There are some papers on this. I just didn't get into this because I only had 20 minutes rather than the full-length talk. And so that's really what I would do. And I would do a more complicated version of what I described. For each path-specific effect, I would figure out what function of the data it is, try to estimate it, and then just report that. We're not quite there yet because this is all preliminary, but we'll see what we can do longer term.
Is there time
Ilya,
for one more
can I-
question? Oh, sorry,
Go ahead.
Dr.
No,
Zier,
you
go
go
ahead.
Go ahead. You get to ask.
All right, I was just wondering, Ilya, great talk. This is Allie.
Yep. Thanks.
Can you speak a little bit about interventions? Because, Dr. Cooper talked about interventions playing a key role with disparities work. And I think that people may benefit from hearing your perspective on how you can use your path-specific effects you were just talking about with mediation analysis to assess and say something about how to pick interventions and where they might have the biggest benefit.
So causal inference is meant to represent hypothetical intervention. So the way I think about causal inference is just predicting what would have happened if we were to be able to do this hypothetical intervention, and even if we can't in principle because of the fact that it's unethical or too expensive or unfeasible. So the way I think about mediation analysis, so analysis of causal pathways, is I try to break up a complicated vector size treatment into pieces that in the data were not really intervened on. Like imagine, you're a smoker, so you get nicotine consumption and smoke inhalation together. So that's like a vector of 2. So if you're a smoker, you get both of those. If you're a non-smoker, you get neither of those. So similarly, if you're African American in the United States, then there's a complicated vector that has to do with what it's like to be African American in terms of health, in terms of culture, in terms of the way you're perceived, in terms of the way structural oppression happens to you, right? So that's, or if you're white, like none of those things happen to you potentially. So the way we try to think about that is we try to think about what it would mean to intervene in a particular component that's associated with a particular downstream mediator. For example,